Good evening. Welcome. I want to thank everyone for tuning in tonight to our orthopedic live stream. This is the first time we're doing this, so bear with us. We're really excited to be able to communicate and try to talk to our team and our medical group and the medical community through this live stream. I'm Jonathan Fallon. I'm the lead physician at Cooley Dickinson Orthopedics and Sports Medicine. I'm excited to be here with you guys tonight with the rest of our team. So first things first, location-wise, we've tried to make our care more accessible, physically more accessible. So we're still at our West Hatfield location, which we've been at for a while. That's our main office. It also has our walk-in orthopedic injury clinic that's there 5 days a week. We have moved from Belchertown to a new office in Amherst, right on University Drive, super convenient. That also has the orthopedic injury clinic. So that's a new thing for us, and also new to us is our Greenfield office. So that's to make it more convenient for those in the north at Franklin County. So those are sort of the physical locations. And then just wanted to introduce you to the team of docs that we have. Dr. David Boardman, who is primarily a joint replacement, joint reconstruction specialist. There's me up there. I do predominantly sports medicine and trauma. Dr. Hoffman, who also does joint replacements and is a fellowship trained foot and ankle specialist as well. Dr. Sherry Kaczynskis, who is a sports medicine trained physiatrist. There's Dr. Mcbride, who also is a fellowship trained sports medicine surgeon and does a lot of joint reconstruction as well. Dr. Schneider, one of our newest additions, who is a joint reconstruction specialist as well. And then Dr. Piatta, who is our hand surgeon. On top of sort of the team, I want to let the team sort of introduce themselves and our service lines and let them tell you how we're personally trying to take care of each one of the service lines to try to improve access for your patients and to improve service. So we're going to start off with the joint replacement service line, and I'm going to have Dr. David Boardman just give you a quick little spiel.
Thanks, John, and welcome everybody. My name's David Boardman. I've been with the group almost 3 years now. I've been in practice as a joint replacement fellowship trained surgeon for over 20 years. And I'm the medical director, if you will, of the joint replacement service, where we still are doing inpatient hospitalized hip and knee replacement surgery at our hospital. And we are presently about as well equipped from a manpower standpoint as we ever have been, as far as being able to get relatively quick access, not just for surgical consultation, but also for actually getting surgeries done. One of the biggest things that's changed in the joint replacement industry in the last 5 to 10 years is the requirement to really understand everything there is to know about the patients to make sure that their hospital stays go smoothly and that our morbidity and risk factors can be mitigated so as to prevent complications. And so probably the major factor in limiting how quickly we can get patients into the operating room is to get a better holistic understanding of all of their medical and dental needs, and to make sure that they're coming into the operating room as healthy and clean as possible. And most of us are able to get patients into the operating room in a 2 to 3 month period, unless they're just so medically complex, there's more delays than that. In addition to myself, we recently hired another fellowship trained joint replacement surgeon, Dr. Ben Snyder. We also have Dr. Mcbride, who's kind of the dean of our joint replacement surgeons, and he has been doing pretty high volume of knee and hip replacement for many, many years. And also Dr. Brian Hoffman, who's recently hired and represents our Greenfield service area, is fellowship trained in foot and ankle surgery, but also is an experienced joint replacement surgeon for knees and hips. And I think with that, I'm gonna pass it to Brian to talk about the foot and ankle service.
Thanks, Dr. Boardman. I just want to say thanks to the group. I'm excited to be here. I'm now in my 8th month with the group, but I've been in the Valley for a while. And Yeah, as Dr. Fallon and Dr. Boardman said, I'm a joint replacement surgeon. I've been performing joint replacements, total hips and total knees for 17 years with competitive outcomes and patient satisfaction. And in addition to that, been since 2009, been performing partial knee replacement as well, also called unicondylar knee replacements. Some patients where only part of their knee is worn out. It's an attractive option. These operations are sometimes associated with less pain, earlier functional recovery, and some patients say they have a more natural feeling to their knee. So it's nice to be able to offer a lot of different options for people with hip and knee arthritis. But it's true, I'm also a fellowship trained foot and ankle surgeon after my general surgery training for a couple of years and then orthopedic residency in New York. I did a foot and ankle fellowship at Duke in North Carolina, where I stayed on for a few years. And I'm happy to provide your patients with consultative services for a host of problems from the ankle to the toes. And speaking of joint replacements, one I'm bringing to Cooley Dickinson Hospital is total ankle replacement as well. The designs are getting better and better, and it's an exciting time to be an ankle replacement surgeon since the first total ankle was put in the 1970s, which was basically an upside down hip replacement. And I'm sure you can imagine those didn't work out very well. But since then, there have been amazing advances, and it's a good option for certain patients. I also offer new techniques in foot and ankle surgery, including percutaneous forefoot deformities and bunion correction, which I've recently brought to Cooley Dickinson. To my knowledge, I'm the first in Hampshire County to be offering that operation, and it's great to get people back and walking with less pain and earlier functional recovery than traditional surgery. So since I've been in the Valley since 2007, I joined orthopedic surgery and sports medicine last September. Easy availability to get me, and as Dr. Fallon said, we opened up a greenfield office. We're there to stay, and the schedule is a little lighter up in Greenfield since it's relatively new to our practice, and not only for people who are sort of between Northampton and Greenfield, but I've seen people there from Hampshire County, Franklin County, even as far as Berkshire County. I saw a patient last week in Pittsfield. It's very easy to get on and off through either Route 2 or I-91. And we're happy to get there. Just we made it that easy to get an appointment. And a final word about availability. It's not just office availability. The practice and the hospital, Cooley Dickinson Hospital, is clearly committed to OR availability. And as Dr. Snyder and I ramp up, we're getting additional time in the operating room. So, it helps getting people into the office, but from there, getting into surgery if there's an urgent need or people don't want to wait too long for elective surgery. So it's great to be part of such a committed and high functioning service line. So thank you very much. Back to you, Dr. Fallon, I guess.
All right, next is Dr. Kaczynskis, who's our resident physiatrist and sports medicine doc. So she's going to talk to you about sports medicine.
So I am one of 3 fellowship trained sports medicine specialists in the office. I've been here since 2008. I focus on the non-surgical aspect of sports medicine, which is 90% of sports medicine. We have 2 other physicians that focus on that, Dr. Mcbride and Dr. Fallon. Dr. Fallon does a lot of work at UMass and sees a lot of the UMass athletes. I've had a lot of experience and worked with Springfield College. I was the medical director for the athletic training program down there for over 10 years. We see a lot of local high school sports, college sports. What I also want to touch on is the real umbrella of sports medicine. So it's not always about team sports. It's about taking care of active people. There's a large group of very active people in the area. There's a lot of runners and cyclists and people that just want to do recreational sports, and this covers all of them as well. So some of the goals that we have is about having people stay active and restore function, and there's lots of different ways and tools that we offer to do that. The most straightforward one is obviously anatomic correction, like surgery. If you have an ACL tear, that needs to be fixed. But what do you do with the 60-year-old who has hip pain or hamstring pain? How do you get these people active? We use diagnostic tools such as ultrasound. We use various types of injections like cortisone, and talk a little bit about biologic injections, ways to help tendons repair, particularly and try to get everybody moving. So that's the goal of our service, and we try to be accessible. Obviously, you know, sometimes that's a challenge, but we're working on that. Dr. McBride, I don't know if you want to add anything about sports.
My name is Dr. Daniel McBride. I've been in the Pioneer Valley since 1996 for 25 years now, 26 years. My primary focus for many years has been sports medicine, the surgical side of it, but also the non-operative side. As Dr. Kaczynskis noted, most of the stuff patients we see don't need surgery. But we are tasked to guide them through their injuries and get them healed, recovered with non-surgical means commonly. But many patients do need surgery, and that's what myself and Dr. Fallon does. For a decade before Dr. Fallon came, I was heavily involved with UMass, still do a little bit of it, but Dr. Fallon is the dominant force there. As Dr. Boardman noted, I also have done lots of joint replacements, total hip and total knee, for 25 years here as well. As far as the joint replacements, I should note, in addition to the total hip and total knees, Dr. Boardman mentioned, and the total ankles, Dr. Hoffman mentioned, our group does total shoulder replacements. That's the third most common arthroplasty, and Dr. Fallon does those. So in addition to hips and knees, our joint center does care for shoulder replacements. I also do low-level trauma fractures like most of us do here. Each of us has a little probably preference towards which type of fracture we do more than other ones. For example, Dr. Piatta would do lots of hand and wrist fractures. In addition to our physician services, our practice, or our whole group has extensive physical therapy practices throughout the Valley. One directly in our main office and in Amherst. And in addition to that, in our Hatfield office, we have what I would say would be a post-physical therapy option, which is almost a gym, and there is a personal trainer person that can take a person that's kind of completed their physical therapy the next step. And there are a number of aging athletes that avail themselves of that. It'd be kind of like a university athlete after they're recovered from their surgery and their routine physical therapy, the trainers take them the next step to get them back to play. And we sort of have that kind of option associated with our physical therapy, primarily at the Hatfield office. That's relatively new for us. It's a quite nice, well-equipped gym, and it has a personal trainer with good medical knowledge about how to get persons safely through that next step so they can get back to their sport or activity that they wish to do.
Thanks, Dan. And want to also introduce Dr. Piatta, our hand surgeon, to talk about our hand surgery service.
Hello, everyone. My name is Dr. Theresa Piatta. I have been with Cooley Dickinson for about 6 years now and in practice for 10 years. I am a fellowship trained hand surgeon. I did fellowship at the Philadelphia Hand Center. Our service line offers a breadth of services for patients with elbow, wrist, and hand conditions, including pediatric patients up through adult and aged patients. We see patients both operatively and non-operatively. So from things like fractures to arthritis to sprains to simple lumps and bumps. There's lots of carpal tunnel treatment, and we have amazing facilities with the occupational therapists in the Valley and associated with Cooley Dickinson that help me be able to be a successful hand surgeon. We also have a great team with physician assistants and Our orthopedic injury clinic certainly adds access to my availability to see patients with hand and wrist injuries. Access to the operating room is second to none. We have an excellent operative team that will keep my availability to do operative cases up and running. And I've been on a brief pause, so the service line has been briefly paused, but we are ready to be back up and running in May.
All right, thank you, Theresa. And so I'm tasked with talking about sort of our trauma. This is a community hospital. We don't deal with a lot of high-level trauma, but really the trauma that is the hardest to deal with is the stuff that doesn't need immediate surgery. And that's the things that are hard to get into quickly, which is why we've developed that injury clinic. And the injury clinic doesn't require any appointments. It's a walk-in or hobble-in clinic, if you will. It started about 4 years ago in our Hatfield office, has been quite successful, and we've now expanded it to the Amherst office. It is run by PAs, but they always have access to all of us, either by digitally or there's somebody in the office that can support them if there's something comes in that is above their sort of pay grade. But for the most part, these PAs have a wealth of experience from pediatric to adult, and they're great at taking care of anything that walks in the door. So we just want to make sure that everybody's aware of that service that's available too. That pretty much wraps up all of our service lines. The only one that really didn't get to introduce himself personally is Dr. Snyder, who is the newest member of our team. So Ben, I wanted to give you just a couple of minutes to say hello, introduce yourself. So you got the mic for a sec.
Thank you, John. I appreciate having the opportunity to say hello to everybody. I joined the group about 6.5 months ago. I came from Plymouth, Massachusetts, which is where my wife is from. Prior to that, I was up at Dartmouth Hitchcock Medical Center, which is where I started medical school about 16 years ago. So I'm originally from Pennsylvania, but have been up in New England for about 16 years. After medical school, I went down to UMass in Worcester for my orthopedic surgery training. You know, it was a big trauma center. Got to see a lot of crazy accidents and cases, but really developed a liking for joint replacement, and particularly redo joint replacements. So I did a fellowship out at Stanford, focusing on joint replacements and particularly revision joint replacements. You know, so trying to help these patients out that have had you know, a hip or knee replacement that has gone bad. You know, and it's something that I brought to the group, having that experience. You know, have a master's in public health that I got up at Dartmouth as well. That really focused on patient outcomes and quality improvement. And those are initiatives that we are incorporating at Cooley Dickinson through the Joint Replacement Center. I'm working with Dr. Boardman, who's the current medical director. And, you know, we've been measuring outcomes, and actually we just got, you know, a certification from Mass General Hospital that we as a group have the highest rate of collecting outcomes. So something we're looking to incorporate to improve our patients' experience and satisfaction. But then also looking at our own quality metrics to make sure that we're delivering the best, you know, surgeries possible. I think we have a very unique experience here that we have a joint replacement center that's really separate from the rest of the hospital. You know, dedicated nurses and therapists, case managers to help get these patients up and get them going. You know, and we're working as a hospital to make, you know, our hospital stays shorter, moving towards potential outpatient joints in the near future. You know, but we're obviously working with, you know, the other teams that are necessary to make that happen, mainly the therapists and case managers, because we want to make sure that we're doing it safely, you know, and have our patients' best interests always in mind. So it's been great joining the group, really enjoying living up in the valley here. It really reminds me of kind of the rural area that I grew up in Pennsylvania with, you know, lots of fresh farm food, you know, mountains to go, bike and hike and ski around, and just a great overall group. You know, people are really happy here. So I'm excited to be part of the team. Thank you.
So just to sort of sum up, you know, we took sort of what we felt were the whispers and requests from the general public. and tried to increase access. We tried to increase access by hiring some more physicians, as well as PAs. We tried to increase ease of access by adding more locations. We've tried to increase access by being able to see our acute injuries more quickly. And currently we're going through a process change to try to be able to see patients more efficiently for the not necessarily new injuries, but new sort of more urgent complaints. And that process is still going through. Ultimately, the overwhelming theme is we want to do what's best for our community. So really the question that we now have for you as a primary care community is, how has your experience been working with our practice? How has your patient's experience been? And what are the needs that we could potentially meet that we haven't met, or could tweak so that we can meet the community needs more effectively? And that's sort of what we would love to hear from you, and have a dialogue about that, so that that we can come to really treat the whole community as best we can. So do we have any good questions? All right, we got a few here. So one of them I have now is, are there any new specialists, anything new on the specialist side of things? Are there any new things to come regards with procedures for our patients? Maybe Ben, as the new guy here, if you've got, if you want to speak to some of the new procedures, especially in the joint replacement world, or new processes that you guys are developing based on those patient-reported outcomes that are so great that we're getting, and how the Joint Center is working.
Sure. So as it's been mentioned by the other members here, we do not only hip and knee replacement surgery, but we do partial knee replacement surgery. We're also doing total ankle replacements and shoulder replacements. So it's replacing most joints in the body. I know Dr. Piatta probably does some finger joint replacements as well, maybe wrists. But I think the new things that we're looking to expand on at Cooley Dickinson is really being able to provide a comprehensive service for these patients, all the way from the non-operative treatment, which can be through the sports medicine teams and Dr. Kaczynskis, but then all the way up through surgery, and then, patients that need revision or redo surgery, and really being able to take care of that whole spectrum. I think we're really focusing on the processes and the protocols to make sure that they're up to date and evidence-based, that are allowing patients to recover from these surgeries quicker with less complications. Looking at their medical comorbidities beforehand. We're opening a dedicated clinic for preoperative evaluation to make sure that these patients are being optimized. As Dr. Boardman said, in doing that, minimizing the chance of postoperative complications, optimizing our before procedure and immediately after procedure order sets, and particularly multimodal pain pathways, which allow these patients to get out of bed the same day of surgery, and get home quicker. And then also working with our visiting nurses, therapists, both out in the community, but then also through Cooley Dickinson to see these patients, through the end. We actually have a class that these patients can attend, for the final touches, kind of a group-based class that they go through exercises and are really helping each other out. So really trying to offer the whole spectrum from initial presentation, non-operative treatment, through operative treatment, through that post operative or post-injury rehab.
In addition, we are not doing this yet. Dr. Boardman alluded to it, and it's definitely slowly gaining steam and nationally, and it was accelerated by COVID, and that is outpatient total joint surgery. Dr. Boardman arranged a conference put on by 5 or 6 nationally known surgeons about how to do it, and it's more complicated than just deciding next week we're going to start outpatient surgery, but we are going to be slowly working towards that, both because at least for some people, we think it's probably a good idea, but also the national trend is that patients seem to be more and more wanting it. So I would say that's we are not doing it yet, but that is a plan and evolution to start doing outpatient total joint surgery. And then particularly for our primary care community, Dr. Snyder mentioned the optimization, and just to let the medical physicians know what we're trying to optimize. There are several things that have been shown that we should be optimizing, and the quote system is demanding we optimize them, and that is diabetes control, smoking cessation, obesity, proper dental hygiene, and then possibly we might be looking into a way to assess decent nutritional status, basically to get all that stuff in line before we proceed with the elective total joints. As studies have shown, if all those are good, we can significantly reduce our complication rates. Another thing that we're doing, it's popular, getting more popular, is some form of computer-assisted surgery. I've been doing that for a decade. And with that type of surgery, we use a computer, MRI or CAT scan combined with computer programs to supposedly get more precise alignment of a total knee than the traditional method. The data that are out there seem to indicate the alignment is slightly better, more precise, although the data at near and midterm unfortunately doesn't show patients appreciate it. But that's being more and more done nationally as some form of computer-assisted, robot-assisted, or computer-robot-assisted surgery. So we are doing that as another, I would say that's another newish entity in the joint replacement service.
There is a question probably best directed towards Dr. Boardman here. I know it's a question that you've heard many times before, and it is about the anterior hip replacement. And there's a question of whether or not there are any plans of incorporating that into our practice.
Yes, that is a common question that comes up. Thank you. In reference to the prior question about new procedures, just one caveat to understand is that orthopedic surgery has always been a subspecialty of medicine that seems very technologically driven. And it also seems that it's very market driven. And the combination of those things gives people the impression that newer is better. And as it turns out, there's really compelling evidence that more than 50% of things that were introduced to market in the last 20 years called new technology have actually proven to be associated with worse outcomes than the technologies that they had been introduced to replace. So there's the concept of jumping on the latest bandwagon, and then there's the concept of kind of remaining kind of grounded and holding to the tried and true proven procedures. I would say as a group philosophy, especially with regard to joint replacement, we do hold steadfast to the proven treatment protocols, and it is uncommon in our group to offer something new for the sake of marketing without really understanding whether or not it's helpful, because there have just been so many stories in recent years about that backfiring. Specifically regarding anterior approach hip replacement, I think it's commonly misunderstood that this is new. It's actually one of the oldest joint replacement approaches. It was invented kind of when all hip replacement surgeries were invented shortly after World War II, and happened to have been by far the most difficult technically to do, and therefore was abandoned for a very long period of time, roughly 50 years, including my training period. Nobody did the direct anterior approach because it was difficult, and I never learned how to do it. The reason it has repopularized itself is not because it's better, it's because it's possible. And because orthopedic surgeons are very industrious and good at marketing themselves, when it came back as a renaissance, it was marketed heavily as better, even though there was never any research to suggest that being actually true. Unfortunately, as I said, this is a very market-driven industry, and patients seem to be asking for it under the belief that it's somehow better. And that is not really actually evident in our research. And if there is an improvement in it, it is very difficult to decipher from whether or not there's patient expectation bias in the reporting of that. And it's only a short-term benefit, if any. So the logistics of converting a service from a traditional posterior approach to a direct anterior approach are rather expensive and difficult. And for a variety of reasons we've discussed ad nauseum and consensus amongst the joint replacement surgeons in our group, we have decided that it did not offer sufficient clinical improvement to make that change, regardless of the compulsion of offering it just to meet the demand. We have spent our time discussing with patients the reasons why the demands is commonly misunderstood, and we have remained grounded in doing the posterior approach. There's a lot more technical aspects to the answer to that question that are probably not of relevance, but I do find myself getting into the weeds and talking to patients about this many times per clinic day.
I'd like to add, John, if I could, to that. So I agree completely with Dr. Boardman's comments. As one of our 4 joint replacement surgeons, I would just want to ask the primary care community that if you have a patient who seems to be interested in a hip replacement and seems to be inclined towards a direct anterior approach to the hip for whatever reason, they know somebody, they read about it, we'd love to have a chance to have that conversation with them. So please don't let the fact that we don't do it in our group dissuade you from having from letting us have a conversation, because we can help try to nail down the reasons why they may be drawn to it and discuss whether there really is any benefit, whether there really is any risk, because I think some of the drivers for a direct anterior approach are more historical than actual, such as potential for postoperative instability, and some of the complications and issues with anterior hip may not be really fully appreciated in this kind of wave of anterior approach marketing that's going on. So somebody who initially expresses to you the knowledge or awareness or desire for an anterior hip replacement, man being somebody who upon reflection and education might not want it and has a beautiful outcome without it. So we'd still love to see the referrals even if patients are inquiring.
I was just going to add a little bit, since I have finished my training most recently, in joint replacement, and I was out at Stanford University, which is probably one of the best hospitals in the country, and they were not offering the anterior approach because it really does not offer, better outcomes. And if you look at it, there's maybe 30% of surgeons in the country that are doing the anterior approach that do hip replacements. In the world, it's only 5%, so this is very much an American thing. And even then, not a majority of the surgeons are doing this. So it does come down to marketing. And the reason that my teachers chose not to learn this method was that, it exposes patients to unnecessary risks that have been mitigated through the posterior approach. Namely, there's increasing risk of injuries to major blood vessels and nerves that can leave the patient very difficult to walk, essentially a femoral nerve palsy. The bone can break when putting the implants into the bone because you just don't get as much exposure. You can't see what you're doing. And then a lot of patients are still left with a numb thigh, even if everything goes well. The same nerve that causes the myalgia paresthetica, that gets injured and it can be permanent. And, that can be pretty troublesome to patients. So, I currently do not do the anterior approach. And a lot of my teachers, have not picked up on it because of the elevated risks. And, we already have a very tried and true approach and technique that, has done very well for the last, 40 years. And, a lot of the improvements in joint replacement have been through, things that you might have not heard about, which is, better pain control, reduction in blood loss during the surgery using tranexamic acid, and then just simply getting patients out of bed, the day of surgery. Patients used to, sit in the hospital for days on end, which has caused more pain, blood clots and such. So, so the anterior approach, it is heavily marketed. Patients may have a little less pain for the first week or two, but then, all studies have shown that the outcomes are equivalent thereafter. So, I don't know. That's just my more recent experience with the direct anterior approach.
So I want to switch gears a little bit with a different question. It was mentioned, orthobiologics were mentioned as a possible treatment. Can you discuss what this entails and who would be the ideal candidate for these types of injections? I guess, Sherry, that's probably a good question for you. You want to chime in on that?
Sure. So there is again, not relatively new field of regenerative medicine. It's been around for a long time. And one of the things that started it was a sort of treatment called Prolotherapy. So the goal was to inject some sort of irritant solution, usually dextrose, into some sort of area of the body that wasn't healing well or wasn't recovering from some injury. And this was done for 50, 60, 70 years. And a subset of that has become orthobiologics, where the theory is, okay, well, if that helps stimulate a repair to tissue, then why don't we use other types of products? And one of the ones that we use here is platelets. So we do a type of biologic treatment called the Prp injection. And the goal is to take a product from the patient. We particularly use platelets. There are other products, stem cells, adipose cells. There are some that are taken from amniotic fluid. So there's a range of these products that are out there. But the goal is to inject them into an area of the body that's not healing. The predominant research, particularly for PRP, has been for tendons. Tendon injuries don't heal well. You develop tendinopathy, tendinosis. And in order to stimulate the body's own natural repair process, this is a procedure where we draw the blood, spin it down, concentrate these platelets, and inject them into this area of tissue. This is done typically under ultrasound guidance. And the goal is to stimulate the body's natural repair process. Sometimes I do them for arthritis. There's a little bit newer research about patients responding to intra-articular injections into the knee or into the hip. I've also done rotator cuff, patellar tendon. A lot of research has been focused on tennis elbow. So there's multiple areas that this is offered. The ideal candidate would be someone that has ideally a tendon injury that maybe they have gone through physical therapy. They may have had a cortisone shot and they are just not better. One of our initial injections is usually cortisone, but although cortisone is very effective, it's a good short-term anti-inflammatory. We know that the long-term outcomes of repeated injections are not good. It certainly can accelerate degenerative changes, can cause tissue damage. So sometimes we use them for diagnostic and therapeutic purposes. And then if we have areas that aren't really responding or recovering, and most of these are really non-surgical issues, partial Achilles tears, gluteal medius tendinopathy, AKA trochanteric bursitis, rotator cuff, partial tears, tendinopathy. These are the type of patients that we offer this type of procedure.
Thanks, Sherry. Yeah, I know we've had some great success recently with the adding the gluteus medius tendinopathy to our armamentarium for treatment. That's been really a great thing for patients. All right.
John, can I chime in there a second?
Yeah, have him jump in.
I'm gonna toot your horn again. John mentioned the gluteus medius, the trochanteric. Am I on here?
Yep.
Yeah.
Yeah.
The trochanteric bursitis, but recent studies and better MRI, et cetera, have shown a lot of the trochanteric bursitis pain, quote unquote, is actually not a bursitis, but trouble with gluteus medius tendon tears. And Dr. Fallon is, the last few years, has been doing hip bursoscopy, not arthroscopy, because you don't have to go into the hip joint, but bursoscopy to actually repair some of these. So a decent number of those lateral hip pains are actually this. And Dr. Fallon could speak more precisely because he does it, but he can arthroscopically repair those tendons, similar concept to repairing a rotator cuff tendon in the shoulder, and he's getting good results from that. So that's another little new thing that's being offered.
Nice, Dan, you're really setting me up here.
That's right.
Thinking it too easy. Yeah, this has actually been a really exciting change in my practice over the last 4 or 5 years. I've been really exploring the trochanteric bursitis pain because, as you said, this is not really a bursitis, but it seems to be a tendinopathy, almost like a tennis elbow. And that's what most of it is. It can be treated non-surgically, and 90% of these are non-surgical. And the PRP injections, recent data has really supported this, that those can be essentially curative with the tendinopathies. But there's also a subset of these patients that come in that are miserably painful, and they've actually torn their abductors, the gluteus medius and minimus. And those patients respond wonderfully to repair, which we can do minimally invasive, a couple of small poke holes. And that's been a lot of fun to see those patients get better. So yeah, that's been a new thing that we've been able to add to it.
Can I ask, I'm going to tout someone else, if Dr. Piatta is still on. This might fall under that, her treatment of Dupuytren's or similar with Xiaflex. That's kind of a biologic treatment as opposed to the old surgical treatment.
Yeah, that is. The Xiaflex is a collagenase enzyme that's used to inject and treat contractures caused by Dupuytren's disease. I have been doing that since the start of my practice. It actually has been FDA approved for about 10 years now. So I've been doing it since I came out to practice. It's an excellent non-operative alternative for patients with Dupuytren's contracture. It has a very minimal recovery compared to surgical open fasciectomy. So that is certainly something that I like to offer typically as a first-line treatment for Dupuytren's disease, but also for recurrent cases or for post-operative cases. If you have a patient that had surgery 20 years ago, if they meet the indications for treatment of Xiaflex, that's certainly an option for them. And a lot of those patients really don't want to go back through the surgery that they had 20 years ago. So that's an excellent advancement, and I encourage everyone to let their patients know that there's an alternative to surgery.
Well, Dan, we should have let you MC this. All right, I got a question from one of our geriatricians who's asking about rounds in skilled nursing facilities, especially in the Amherst Greenfield area, for the scheduled non-acute visits. This is a tough one just because of sort of limited manpower, but at the same time, and that I think that this is something that sort of this whole COVID pandemic might have added another tool for us to be able to do more. I know we've been dealing with Dr. Redwood and Dr. Most in the hospital to get the geriatric, I don't even know, demarcation, if you will, for the ER, creating a better pathway for a lot of the hip fractures. And that's really where we see a lot of our geriatric patients. I mean, we do probably fix 100 hip fractures a year. And so, although Dr. Piatta, I think, does most of them, she's a black cloud on call. So we've been trying to create that a better pathway and a better way to take care of these patients longitudinally. And I think with the sort of introduction of these video visits, I think that would be a great way to take advantage of technology and really extend our reach and our ability to interact and maintain the continuity of care going out. So that is definitely something that, is an interesting possibility going forward, and something we should kind of keep in the back of our mind as we're trying to complete this hip fracture kind of continuity of care pathway. I don't know if anyone else has any other input on this. I know the hard part really is for us, it'd be hard for us to get there, but it's also hard to get x-rays. So there's some technological hurdles to get over, but it would be an interesting way to really take care of these patients that we see that are so fragile more completely. Well, from sports to geriatrics, that was sports to hand to geriatrics. That was quite a twist. Let's see what else. We got a couple more questions here. One of them actually is an update on accessibility. People have got a couple questions about how long does it take to book out for joint injections, joint replacements, and appointments. And is there anything that we, meaning the primary cares, can be doing in a way to help guide that booking process? David, I don't know if you, or actually Sherry, if you could just maybe address some of the joint injections, because you do a lot of the arthrogram injections.
Yeah. Yeah, so a lot of the cortisone injections and quick injections, I do blind. So if there's a patient that is established with me that wants to come in because they need a cortisone injection once a year and need a tune-up, we can easily double book them. They can call, I can get them into my schedule within the next couple of days. Some of the guided injections take a little bit more time. The joint injections we do under fluoroscopy. We need an x-ray tech, we need the fluoro room. So it's a little bit more involved. A lot of the tendon injections and ultrasound guided therapeutic things that I do, aspirating Baker cysts, injecting various things, also take some time. So it's not as much as the access, is just the length of time some of these procedures take. But if the patient is just trying to come in for a quick injection and it's appropriate, then if they're established, I can always double book them. The other ones though, it's a challenge.
Yeah, I think it's fair to say, David, and maybe you could nod or Ben or Dave or any of the joint.
Yeah, one thing I would say about getting total joints in the queue quicker, getting back to some of these factors that limit getting into the queue, these quality things we're trying to do, good diabetes control, obesity, smoking cessation. It would probably be really helpful if we got out to the primary care doctors some of the factors that would prohibit a patient getting in. So if they're, for example, we like the A1C for diabetes to be under 8. We like them to have stopped smoking. We like their BMI to be under 40. All of these are kind of growing national standards. So starting the patient, even in the primary care doctor's office, letting them know these are going to be factors that will restrict your being able to even get on the total joint schedule. And the patient and the primary care doctor can start working on these issues even before seeing us. Then once we see them, if they're under much better control, there won't be this lengthy or it won't be as lengthy a issue about getting all this under the control after we've seen them, and thereby lengthening when they can even get on the schedule.
That's a great idea, Dan. We should probably think about putting something a little more formal together so that we can get that information out to primary care docs so that they know when they're sending a patient to us, this is what's, this is how to speed them up. This is how to jump them ahead of the queue if they're already teed up and ready to go. That certainly would be good for patient convenience and expeditious care. I think it's fair to say at this point, we've knocked down that timeline for joint replacements. At one point, we were up to 6 months to get to a joint replacement. I think now it's certainly reasonable to think we can get somebody in within a month or two if they are, not uncomplicated and don't need an overwhelming workup. It does take a certain amount of time just to kind of go through the process and make sure we're doing it right. I did get a question about whether or not urgent care providers can call and speak directly to any of the ortho providers about issues that may be sitting in their office that they have questions. And the answer to that, I think unanimously, is yes. We try to be as accessible as possible. Certainly, the injury clinic is open 5 days a week. So Paul and John are very much interested in talking to people on the phone and sort of guiding them through that. And certainly we are available as much as possible as well. So we're all happy to talk to somebody if they have questions. Certainly, if we have questions about hypertension, we're going to call you.
Hey, John, can I add something to that too? In today's technology, I guess if they had Cortex, if primary care has their own X-ray, if they could send a picture with their info, or if they have a bursa that they think needs to be drained, if they send a picture, we could say, yeah, that does look bad. Or sometimes our impression of bad is different than their impression of bad. And even if we say, oh, that doesn't look so bad, we could see it in the next few days, that could at least reassure them. So if the primary care docs have access to secure messaging, so they could send a picture or a picture of an X-ray of something they might want us to look at, that could be helpful.
If I could chime in on that, as a specialist in the community, there's no question that one of the biggest obstacles I have to care delivery is how fragmented the healthcare system is in the Pioneer Valley, mostly because of electronic medical records restrictions. And when a patient comes to see me whose primary medical doctor is ostensibly sending me a referral that isn't in our Cooley Dickinson system where I can send them an easy staff message, I feel like it's a more challenging process to feel like I'm on the same page. And that's not something that I have a magic wand to fix, but I did just, we did have a slide that we were going to project at some point, which has direct email addresses for all of us. And I would very much encourage any of the primary care doctors, especially if they were going to be wanting a more safe handoff of this particular case, to contact me by email. And if there's a number of primary care doctors who have kind of been frequent flyers for referring patients to see me. We ended up just trading cell numbers and text each other with reckless abandon, just to make sure that patients don't get stuck in the middle. And so I think I'm speaking on behalf of all of our physicians here. If you take a snapshot of this slide and keep our email addresses on hand, we're all pretty good. It's not a non-urgent means of communication, but if you feel like you need to get a hold of somebody, and this is a simpler way to do it, and we would all kind of definitely encourage you to reach out to us more personally.
All right. Well, so thank you, David, for teeing up the final slide here. So this is all of our email addresses, and at the bottom is our office manager. So if there are any questions that you're not sure who to direct it to, Courtney is great, and she can certainly get any questions to the appropriate person, certainly. And if you send it to me and I'm not the one to be answering it, I'll have you to forward it on to the right person too. So I guess this pretty much closes it out. I wanted to thank everyone for attending from the comfort of your home. Remember, this recording is available, so if you want to go back and rewatch it, you're more than welcome to. Feel free to share it with your colleagues. Honestly, the phone lines are open. If you ever have any questions, we're all here. We're all happy to talk. So thanks again for taking you the time, and take care.